Pleasure to be here. Listening to the introduction, I guess it's a sign as you get older, you're more former things than present things. Okay, well, I really do appreciate the opportunity to talk to you. Epidemiology is not my area of training, as you heard. It's really more medical genetics, but I have found myself over the past few years involved in a number of things that really do touch on the world of population health and epidemiology. And if you think in terms of genomics on a population scale, and I'm thinking especially of the ability to do genomic testing on a proactive basis across large populations, there are both benefits and risks, and a lot of research to be done to clarify these. The potential benefits would be early detection, finding people at risk of a condition they might not have known they were at risk for, and for which there is an intervention that you can offer, and do proactive management to have a better outcome. In a broader sense, and probably more on a research than clinical basis, if we're going to realize the dream of precision medicine, which is identifying people at risk and offering them a pathway to risk reduction or more precise targeted treatments if they do develop a condition, that's going to happen because lots of data were collected that informs that kind of issue. Our risks, though, and undertaking this kind of population approach, I'm by no means trying to enumerate them all, but they include anxiety if somebody learns they carry something that may or may not actually ever come to roost as a medical condition. The inverse of that, false reassurance. I participated in a study and didn't hear anything, so I must be fine and don't have any risks to worry about. And there's a concern, too, about access, that when you do a study of the kinds I'll be talking about, what efforts do you make to reach out to communities that might not otherwise be empowered as well to participate in research and for whatever reason might not benefit individually and over time might not benefit collectively. And so this is not without its risks as well as benefits. But that's what makes this whole domain one worthy of research. And what I'll try to do today is review for you two programs. I think the title really focused more on the one on the left, the Alabama Genomic Health Initiative. But I think it's also pertinent to talk about the All of Us Southern Network, which is a much larger program and yet one that shares at least some similarity to the Alabama Genomic Health Initiative. All right, so let me introduce AGHI as we abbreviate it. We're in year 4 of what we originally were expecting or hoping would be a 5-year funding period, and it is funded by the state of Alabama. We've gotten $2 million a year each year for these 4, and we're hoping to convince them that this is a worthwhile program to continue for the long haul. And the value proposition, what was the original proposal and argument, is as follows. The stakeholders are participants who sign up, health providers who provide their care, researchers, and the state in general. And as you will see, participants get a return of results of things that we believe may make a difference for their care. I'll say more about that in some detail. Health providers are informed, and you'll see under what circumstances, about results that are relevant to their patients, and they get educated as well, so that they're not sort of left hanging wondering what to do. We've built a resource that we hope will increasingly be used by the research community at UAB to give them access to information about genomics in the regional population, and I'll say more about that. And from a state's perspective, it is a way to make both a healthcare workforce and a population kind of more, you might say, genomics ready, more familiar with genomics, less intimidated by it. In principle, if grants are issued based on discoveries that were made, this could be imagined to help with economic development, theoretically even through launching companies. And it doesn't hurt to have a sense of being on the cutting edge. There are a lot of people who are involved in the program. I'm not going to try to name them all, but I think the thing to keep in the back of your mind is this is a real kind of community effort to make this kind of thing happen. Rather than naming them, I just want to point out some of the expertise that we've been able to bring to bear. We have a committee on informatics and biobanking, one on community engagement. There is a bioethics committee. There's an outreach and enrollment committee, an education committee, and a genomics committee. And the good thing about these committees, which is not a given, I'm sure you'll recognize in many areas, is they're actually active. They're engaged. We meet regularly, and there are really tangible products that have resulted from these. So whatever else has been accomplished, bringing people together over a really well-defined project has, I think, been already a significant success. AGHI involves recruitment of two cohorts. We call one the population cohort and the other the affected cohort. The distinction is the population cohort are basically adult volunteers, and that's all we need to know about them, other than that they reside in Alabama. We felt an obligation to ensure that, given that this is being done with state funding. So it's Alabama residents who are adults and willing to participate, basically. The affected cohort are children or adults with a phenotype that is suggestive of an underlying genetic disorder that has not been diagnosed, and where it is deemed that genome sequencing offers a possibility of establishing a diagnosis. So the population cohort have genotyping done using the Illumina Global Screening Array. I'll show you more about that in a few minutes. There is a variant analysis done, and they get a return of results of actionable variants, more to say there. They get genetic counseling, and then they get plugged into supportive care, which is sometimes at UAB, but it may not be. As you'll see, people are dispersed all over the state. I should say that all of the genotyping and analysis, and actually some of the genetic counseling, a lot of it actually, is done at Hudson Alpha Institute for Biotechnology in Huntsville, who are our partners in this effort. The affected cohort get whole genome sequencing at Hudson Alpha, an analysis seeking pathogenic or likely pathogenic variants. There is a return of results of anything that we think is related to the etiology of their condition. They also get genetic counseling and the same supportive care. And they're all offered an opportunity to have DNA and generally plasma bank. That's the only tissue we're seeing. We aren't doing biopsies or anything. To have that biological material kept in a tissue bank through the CCTS, actually. A genomic database is maintained, and medical records are shared if they're UAB patients, which not all are. And actually the genomic data, together with the medical record data, which normally resides there, are kind of merged into the I2B2 database you may be familiar with, which is a mirror of the electronic health record that's used for research purposes. But now if a person is an AGHI participant and they have opted in to allowing the sharing of this information, then all the genomic data is put in. Now, to say all the genomic data, right now it's just the genotyping, not the whole genome sequencing, although there is interest in getting the whole genomes. The trouble is that the data storage requirements are obviously much more significant. So enrollments have been going on now for about 4 years. This is a tally of the demographics, looking by race and sex and ethnicity. We've actually done fairly well in recent years at mirroring the demographics of the state. That was not true early on, where there was a much greater preponderance of white participants than Black or African American, for example. Most of that's been accomplished, I'll show you in a moment, by setting up pop-up clinics, or in some cases more permanent enrollment sites in regions of the state where there's a higher concentration of individuals historically underrepresented in biomedical research. We haven't been able to crack this female predominance, and there are various reasons for it probably, but it remains a bit more skewed towards females than males. As mentioned, we do a number of pop-up clinics, and for example, the infirmary health that was done in Mobile in Baldwin counties in October was a 3-day event. I think they enrolled, if I remember right, it was close to 500 people in that short period of time. So it was a very intense, well advertised, well orchestrated, but finite enrollment period. And not a pop-up clinic, but we have an active enrollment site in Selma at a UAB site there, and it's been a very productive one. So here's where we are currently in terms of enrollment. This is, when I say current, it's about a little bit less than a month old. We update these about once a month. So as of January 31st, at least, there were 6,200 roughly participants. Our ultimate goal over 5 years is 10,000. And you might say, well, we're pretty far from that if we're in year 4 and we're only at 6,200, but pretty much the first year was building infrastructure. So we haven't been enrolling for all that time. And at this point, we're pretty well on track to accomplish the anticipated 10,000. We've covered all counties in the state, and there are 89 individuals who have had a return of results. And I'll show you in a few minutes what the kind of menu of return of results looks like. And the number of 1.4% receiving a return of results, that's really held very steady for almost the entire duration of the study. The age range is, as you can see, it peaks in the 50s. There's a fairly small number of younger individuals and obviously a small number of very old. You'll see later, I'll show you a little bit of data about why people are interested in doing this. So the population cohort are analyzed using the Illumina Global Screening Array. So it's 700,000 roughly genetic variants, mostly single nucleotide variants and indels. It is possible to detect some copy number variants on this as well. It has a coverage of minor allele frequencies that are greater than 1% across multiple populations, and not only does it allow for imputation, but that's actually been done. Mary Lynn McDonald was funded a year or so ago to do imputation, and so there's like 2 million variants that have been imputed, and all of that data is also available through the I2B2 system now. And then it also is enriched for certain areas of interest, including known disease associations, a variety of pharmacogenetic markers, and other content that is deemed to be potentially interesting from a clinical or research perspective. This is a list of the genes that are scrutinized for return of results. And although it doesn't say this here, what it is derived from is a list of actionable variants identified by the American College of Medical Genetics and Genomics in the context of sequencing. A few years back, as genome sequencing was beginning to happen on a clinical basis, the concern was, well, what happens if you just stumble on something that wasn't the reason you were doing the sequencing, but you can't ignore it? The most obvious would be a BRCA1 or 2 mutation that is associated with hereditary breast and ovarian cancer. Well, the idea was that it's a little bit like the equivalent of seeing a shadow on a chest x-ray done, let's say if somebody was in a motor vehicle accident, and you want to know if they broke a rib, and by the way the radiologist sees what might be an early lung cancer, they're going to report that. In fact, they could even face liability if they don't. Well, we were thinking, if you do sequencing, let's say a child has intellectual disability, but you happen on a BRCA1 pathogenic variant, are you under a similar obligation to report it? And so they've created this list. What it takes to get on this list is that it is associated, the gene variants are associated with a significant phenotype that wouldn't always be obvious clinically, and for which intervention exists to reduce the risk of disease. Like in the case of hereditary breast and ovarian cancer, surveillance, chemoprevention, surgery, things like that. And where there was good evidence that the variants do predict risk. So we co-opted this list, even though it wasn't really designed for this purpose, and the genes, which I won't try to name, been into tumor predisposition syndromes, connective tissue disorders that predispose to aortic dissection mainly, cardiovascular disorders causing arrhythmia or cardiomyopathy, some metabolic disorders, mostly hypercholesterolemia, and then just a couple of pharmacogenetic variants that predispose to malignant hyperthermia. This syndrome of sustained muscle contraction when exposed to a particular, pretty commonly used set of anesthetics, and the presence of these mutations predicts that that individual is at risk for this and means that they would get a different kind of anesthetic. The ones that are in red are the ones for which we have returned results. So the ones in black, nobody yet has been found to have a pathogenic variant. I'll tell you that when we report these, we always do a verification of the finding in a CLIA lab. That's a Clinical Laboratory Improvements Amendments. That's what it stands for. Basically, it's the kind of accreditation process nationally for clinical labs. And the reason for that is we know that people may then begin to use this for clinical decision making, and we wanted to make sure that if we return a result, it's rock solid, correct, that it's there. And I'll also tell you that the global screening array, when it comes to rare variants, there are lots of errors actually. False positives are not rare, and that's become obvious to us when we do the Sanger validation. Some of them don't validate, and that's a known issue. It's not a surprise, really, given the technology. But it justifies this effort to do Sanger validation of everything that we see. So people get a formal, clinically validated laboratory report if we find something. If we don't find anything, they just get a letter that says it was an uninformative result. We don't tell them you're negative, because we don't want anybody to think that this now gives them a clean bill of health. You know, the risks of false reassurance include, number one, I don't have a BRCA mutation because they looked at it and they didn't find one. We know that the global screening array does not cover all possible variants, especially rare ones that are maybe so-called private mutations only found in one family. And furthermore, there are many genes that would be on a test panel if you came in clinically for breast cancer, let's say, which are not on the global screening array. So we don't want anybody to think this is to substitute for a clinical test. So we don't tell them you were negative, we just say it's uninformative. Or if it's informative and we find something, they get a formal report. And they also get genetic counseling, either face-to-face or by telephone, and then if needed, we will help to connect them with a clinician. The other thing that happens is when they enroll in the informed consent process, they also complete a questionnaire of family history, and it's focused on the conditions that are on the list you just saw. And each one of these is reviewed by a genetic counselor, and then they get into these three categories. Green means there were no concerning kind of issues in the family history. Yellow means that there were some things that caught the attention of the counselors, don't constitute formal kind of criteria for a genetics referral, but are still noticed and are called attention to. And red means that there are things in the family history that convey a significant concern, and there are formal criteria for this, of a genetic problem, and that it's recommended that a formal counseling session be provided, though, of course, it's up to the participant if they want to do that. So it turns out, over the 4 years now that we have been doing this, that 92% consent to having their data stored in the database and their blood and DNA stored in the tissue bank, which somewhat surprised us that the uptake would be that good. You'll see later a little bit about why. There are a very large number of plasma aliquots, sometimes several per participant, which is why the number is so high. As of when this slide was made a few weeks ago, over 5,000 DNAs. Not all of the people who have been enrolled have all the way gone through the process. So that's why we don't have quite the same number of specimens. And now all the bloods are received in the Hudson Alpha CLIA lab, so there is a kind of CLIA dual chain of custody. We're in process of incorporating the data into the Ubright system. I don't know if you're all familiar with that, but this is something that the Informatics Institute has spearheaded as a platform that would facilitate using large data sets for research of all different kinds. And so right now, it isn't fully populated in terms of AGHI, but I'll show you in a minute what we're hoping to see happen. So from a research point of view, if you look at what are the data types that we have, there's the I2B2 clinical data, for those that are released in the UAB system, the genotyping data, pending our ability to store it all here, which is being worked on, all the whole genome sequence data will reside here too, and the imputed genomic data. And this is from everybody who has consented to allow their data to be shared, which, as you heard, is 92%. And by the way, the consent includes consent for recontact for future research too. And then the biomaterials that are listed here and which I've already talked about. So what kind of research could one imagine doing? And there are a few case examples. I don't know that this covers all possibilities. One is that if you have a variant in mind, and this has already happened where one group did, you can say, how many of your patients have this variant? And we can go into I2B2 right now and answer that question. If you have IRB approval to get specific clinical data, we can even tell you what clinical features characterize these individuals and recruit them to participate in a further study of that. Or you might want to do a GWAS or a PheWAS study, and you can do that now as it stands. There's enough data in there, although 5,000 you can decide is either a lot or a little when it comes to doing these. Really well-powered studies could have 100,000, and we're not going to be functioning at that scale. But you can take a look at anybody with type 2 diabetes and scan the entire 700,000 or 2 million imputed genotypes and see who has what variant that might be more enriched in the diabetes population compared to another. Or you can do it in reverse, a PheWAS study, and look at a variant and track what are the kinds of phenotypes that occur. An analysis has been done. 100% of the individuals have some pharmacogenetic variant that in principle could be actionable. We're not returning that right now. I'll say more about that in a little bit, but it is there for research purposes. And also one could begin to use this, and you'll see in a minute that we are interested in doing so, for polygenic risk scores. So the infrastructure is you might do a GWAS study comparing diagnosis or non-diagnosis and getting all the various information, and then with IRB approval have access to specific reports about individuals, or a PheWAS study, likewise with or without a variant, what are the various features in I2B2, and once again can get deeper into this if you have IRB approval. I think the goal here, it's not yet to that point, is that UBright would permit a fair amount of self-service so that it wouldn't be necessary to do this by contacting anybody. I don't know if that I'll, for lack of time, go into too much detail here, but the idea is the researcher could use UBright. There is the opportunity of getting a research consultation, because some will have more sophistication than others. Aggregate data you can get without IRB approval. If you want individual data, it has to be through, you have to have an IRB approved protocol, and you may even then be able to recontact the AGHI participant. Just a word about the other side of this, because everything I've said so far really mostly addresses the population cohort, but in the affected cohort, there's a lot of overlap with the Undiagnosed Diseases Program, which includes a set of physicians and nurse practitioners. And we get referrals, mostly from the region, but to some extent from around the country, of people with chronic undiagnosed conditions, things that usually have been worked up to some extent in the community without an answer, and now they'll come to us to see if we can perhaps crack the kind of diagnosis. This is a compendium of our first 6 years of activity when there were about 500 plus referrals. Not everybody is accepted into the program. There is a review, and a good chunk of them are either declined or referred out. And the reason that would happen is either one of a few things. One is We get a fair number of referrals from people who there isn't a lot of objective evidence that we're going to be able to find anything, aches and pains and non-specific complaints that are pretty difficult to get a handle on. And frankly, there are people out in the community that are just, convinced that they're sick and their doctors can't find anything and nobody can, and it's not 100% clear that they really have anything. And we are a little bit wary of getting involved in those kinds of evaluations for fear that it'll never end, because some of these people are pretty obsessed by their condition. Secondly, we will refer out if somebody is kind of obviously dealing with a very single system focused disorder, like say a neurologic disorder, and they've never been seen by a UAB neurologist. So before we get involved, because we're a multidisciplinary team, we'll refer them to a neurologist. Sometimes it's because they haven't really been that thoroughly worked up in the community, and maybe a specialty would be better suited to that. And there's some that, everything under the sun's been done. It's not totally clear how much we're going to be able to help. So the 226 evaluated as of October, 97 had a diagnosis. There were many concluded without. A few lost to follow-up. At that time, some had ongoing evaluations. And there were some that we queued for annual reevaluation. So I don't know, you can see it half empty or half full. 97 out of 226 got a diagnosis. That's under half. But on the other hand, remember, by definition, to get into this program, you have to have been wandering the wilderness seeking a diagnosis for some time. And pretty much all the conventional things had to have been exhausted. So these are not people off the street who have, a problem and now we're the first look at it. We're usually at the end of a long line of others that have tried to make a diagnosis and been unsuccessful. So the fact that almost half of them come away with a diagnosis, I think is a pretty good track record. If you look at the kind of specialty breakdown, a big chunk of them are neurological or neuromuscular disorders. Rheumatologic are next in line, intellectual disability, immunologic, pulmonary, and then a little bit of everything. I'll say not only does genome sequencing help us, but we do have conferences once a month with many of our specialists. We alternate pediatric or adult, and a lot of the diagnoses get made because of the conversations around the table. So as of a few weeks ago, over 500 whole genomes done, but that's 234 families, and the reason the numbers don't match is where possible, we test a trio, which is parent and both children and both parents, because it's a lot easier to interpret a de novo variant if you have the parents to say that the variant wasn't inherited from either parent. 108 had some variant returned. Pathogenic are the ones we're most confident, explain the phenotype, likely path, not formally proved, and there are formal definitions of these I won't go into. We will return variants of unknown significance here. We do not return them to the population cohort because we don't have enough confidence that they're associated with pathology. But we will in this group because if there is a plausible case that can be made that this might be pathogenic, we think it's appropriate to discuss it with the family with appropriate caveats. And as you can see, the return rate's about 43%, which is pretty reasonable and accords with what a lot of groups do. We have done a survey of why do people get involved, and the most common reasons were to contribute to research, and that may be why a lot of them are interested in opting in to the database and biobank. Concerns about personal and family history is a big one, general curiosity, and then I won't name them all, but a smattering of other issues. Surprising number in a way to us at first, but maybe not so surprising, have discussed the results with their health provider. A high proportion have not. Of course, remember, most 98.6%, I guess, are getting non-informative results. I'm not sure there's much to it to describe to the health provider. And when you look at why, it's a smattering of reasons. Some haven't gotten around to it. Some didn't think they were important enough, which I think in a way is reassuring to us because that would have been our expectation too if you got non-informative results. High proportion have shared this with their family members, which again doesn't surprise me too much. Very few have done anything, partly because the majority are non-informative results. And why not discussing them again? Most because they're non-informative and they didn't think that they were of enough significance to be worth it. How many made a change in anything? Very few changed their insurance. Interesting to us, 12% say, I mean, we don't have proof of what they did, but they did something in the area of health and wellness. And that's interesting because only 1.4% got a result that directly bore on their health, but a higher proportion say that they're doing something, whatever that might be. A fairly small number have tests and medical exams, and that's probably pretty similar. That is pretty similar to the number who get actionable results, so that doesn't surprise us. Most are pretty happy with the experience, so it's a fairly small number that thought this was kind of useless, and most have been pretty happy in general just with the overall experience. Where it's going over the course of this coming year, we're doing a more formal outcomes assessment, particularly of people who got actionable results. We have developed an ancestry visualization. There hasn't been that much demand for it, so we're not pushing it, but we can give a snapshot of continental ancestry based on ancestry informative markers. There has been an analysis I mentioned about pharmacogenomics. The reason we haven't returned results, though, is that there's concern that if you return a pharmacogenetic result to a participant, they're not going to know what to do with it, and probably their doctor isn't going to know what to do with it, and who knows if it's going to even get into their doctor's hands. And finally, most of them are not on a medicine at this moment, which would be influenced by this result, and we're concerned that it isn't going to be remembered what the result was the day in the undefined future that maybe they are in such a medicine, and at worst they could even incur some adverse event that could have been prevented if only people had remembered that it was there, but they hadn't. So we feel like it's just the systems for acting on this are not there, whereas if you get a result today that says you're at increased risk for cancer, there's a well-defined path of what to do next, and it'll happen right now. The GWAS and PHWAS, I told you we're trying to work with URITE to put it into a system where it becomes user-friendly and ready to be used by the community. There is a database now of regional frequencies of alleles. We have a lot of data from people in our region, and that can be used to interpret results going forward when you see a rare variant. And then two things we're working on now is beginning to calculate polygenic risk scores for common disorders. And the question is, how do you deploy this? And we're putting together a pilot where we'll be integrating AGHI into 3 family practices in the community, and then actually working with the family practitioners to help them to learn about these results, return the results through the family medicine practice, and to calculate polygenic risk scores, probably for just a couple of things right now, and see what it's like to incorporate polygenic risk data into routine care. So I'm going to switch gears now and talk instead about the All of Us research program, because as I say, it's got some points of similarity, but of course significant points of difference between this program, but something it's really worth your knowing about, because a lot of data is going to be made available to the research community, and I think groups like this could very well be interested in taking advantage of that. So the Southern All of Us Network, or I guess it's officially the All of Us Southern Network, and I'll show you later on what it is, actually is co-PI'd by myself and Beth Lewis. And it's part of this national program which has the goal of gathering data from 1 million people across the country, reflective of the diversity of the country. And there'll be data sets of various types, including genomic, but not by any means limited to that. Everybody is asked to share their electronic health record with the data center, which is at Vanderbilt, and the goal is to correlate variables from their health record, from questionnaires they fill out, from environmental data, from fitness trackers they may wear, and from genomics and other things to really fuel the precision medicine discovery pipeline over the course of really a current generation. You can imagine different stakeholders here, individuals who will benefit because in the long run there will be a opportunity to understand better who's at risk and how better to treat them, and so we hope will benefit individuals in the population. And I will say participants get full access to any data that is generated, so there's a complete transparency of data for participation. Health community will benefit because we'll have a robust data set to base precision medicine interventions over the course of time. And it will fuel a tremendous amount of biomedical research, and I'll show you later how to get access to the data to do that. There really is a mindset in this program of building relationships with participants. Participants are represented on pretty much all of the major committees, putting the protocol together, any modifications to it. So this is not a paternalistic, we'll devise a protocol and trust us, this is good for you. There really is a very robust community engagement effort. Also, researchers are defined broadly. They're not just biomedical researchers in academia. They could include industry, but they can actually include so-called citizen scientists, a person working in their garage, can include high school students and college students, and a much more broad definition of researchers. Now there are, later on I'll show you security and ethics kind of restrictions, but that being said, this is not strictly an academic enterprise. So innovations include, it'll be a very large cohort and with really diverse data sets collected, not just genomic and not just phenotypic. As I mentioned, participants are true partners in this research, and it is going to be very widely open for analysis. So the kinds of things that are involved from a participant's perspective and where data are collected, the entire thing is done online, so there's no paper forms, which is an interesting decision given the fact that if you're trying to reflect the diversity of the country, part of that diversity includes people in underserved areas who might not have access to the internet, and that's an issue I can tell you we're trying to address, and I'll say more about it later. But anyway, individuals sign up online, but they can also walk up to a kiosk where this is being done and sign up there. They give consent to participate, and they consent to sharing their electronic health record. And there is a mechanism for doing this if you're not part of an academic or a health center in general that has an electronic health record. There is a so-called direct volunteer pathway as well. There are a bunch of surveys a person would fill out at the time when they enroll, and then additional surveys may come their way over time trying to get health information. I will say the group that are creating this are very, very adept at making user-friendly, easy to interact with surveys. You still have to have internet connection, so I wouldn't say it's totally accessible, but the surveys are quick, easy to fill out, very professionally designed. When you sign up, you get some basic physical measurements that are listed here, pretty obvious ones. And that information is returned to you. You might say, well, big deal. You learn what your heart rate is, or you learn what your weight is. You probably knew that, or certainly could have known it. And that's true. Right now, that kind of return of information is pretty limited. Although I will say, having been a participant myself, that I had never, ever in my life had my blood pressure taken as carefully as it was done that day. Not by my primary care physician or anybody else. So, that was, I did learn something from that. Maybe others do too. You give a blood and a urine sample at this point. No other biospecimens are collected as of this stage. And there is an emerging ability for wearable apps like Fitbits and things like that. Integrations are continuing to be worked on. There are lots of players here. The Data and Research Center is a collaboration of Vanderbilt, a company, Verily, and the Broad Institute in Boston. The biobank is at Mayo Clinic, and every once in a while it shuts down for a day because it's too cold or there's bad weather. There is a technology center, which is what generates all the web-based materials, which is a company called Vibrant Health. Genomics, I'll say more about, is a collaboration of Baylor, University of Washington, and a company called Color Genomics. There's a participant center and a direct volunteer network, which is run by Scripps Institute. There are many health provider organizations, of which we're one I'll show you in a minute. And then there's a communications and community network. Wondros is the company that runs that, and then lots of community partners. So this is a screenshot just of major consortium members, not including the community partners. I didn't bring that one. That's a huge slide. Just by way of reference, we are here. This is a big chunk, and we're one of the bigger health provider organizations, and I'll come back to that point later. Needless to say, if you're asking somebody to share their electronic health record, that's a pretty big ask, and it raises lots of questions about privacy and security. Won't go into detail here except to say that it's recognized to be a major requirement for the success of the program to deal with this, and it is without, I'm not an expert in this area, but with state-of-the-art security built in. And it's important to realize too that there is a certificate of confidentiality that covers this program, which by the way is also true for AGHI, so that the data here cannot be subpoenaed, for example, by a court and released. So, these days people hear about these stories of criminals being caught because they shared their data in genomic data, public genomic databases, and whatever you may think about that, that will not happen here because these are not public databases, first of all, and secondly, there is a certificate of confidentiality that would make them inaccessible to the courts. From your point of view, one of the things that may be of greatest interest is the All of Us Research Hub. And as of now, the URL you see down there, researchallofus.org, is open, and you can currently get some kind of broad data from that, and over the course of the next few months, it will become richer and richer. So as of last night, actually, I think is when I made this screenshot, there were over 335,000 participants, about half that number of electronic health records, and the reason for the difference is that there's kind of a batching of sending electronic health records and a large number of biospecimens. Also, not every participant is a so-called full participant who has gone all the way through the process. But there's a lot of other data that you can see if you go on to the Research Hub. But the real question I think that would probably be of greatest interest here is not that kind of big picture aggregated data, but what if you actually want to work with the data in a serious way and you're interested in accessing genomic data from 1 million people and studying it for traits that you're interested in. So this is not yet launched. It will be later this year. But the plan is that it's going to operate on a kind of workspace basis. And what that means is that you are not going to be able to go on to this and say, I'd like to download all your genome sequence data from 1 million people, or even from one person, and play with it, and bring it into your ecosystem and do with it as you will. They're going to create tools on their system that you can use. So if you have IRB approval, and there's a set of hoops that you have to jump through to agree to data privacy and security requirements and ethical requirements. But and it might require you to take some online videos. But at the end of the day, if you kind of pass all of those obstacles, you will then be given a workspace that you can work in their environment. So you cannot download the data to yours, but you can work on it in this workspace, which will be rich in terms of tools that will be available for analysis. And what will happen if you've got a unique tool that's not there, I'm not sure they've said, but my expectation is you would contact them and work with them to make that available. You can do searches even now. This is a search, or this is the kind of search you can do. If you want to know today how many people have cardiomyopathy in this database, you can find that out right now. If you want to know how many have been exposed to some drug of interest, you can find that out. There's a lot of lab data there, not genomic lab data, but CBCs and creatinines and things of that kind, all of that. Surgical procedures, that's all there even at this moment. And although you won't be able to retrieve individual details, you can create data sets as it stands even today of aggregate numbers of this. And to drill down in more detail, that's going to require the research workspace, which will soon be launched but isn't quite ready. So a lot of people assume that this is fundamentally a genomics project. It really is not, but of course genomics is a big part of it. So I mentioned earlier the genome sequencing groups that have been brought into this, and they're in the process of developing the pipeline. And Color Genomics was awarded the contract to do the genetic counseling. I'll say more about that in a second. They will return secondary findings, and if this table looks familiar, it's because it's the exact same set of findings we're returning in the AGHI project. As a matter of fact, I think I must have provided them that table because it's in the same format as the one that we've been using. There's going to be two steps to this. There's genotyping, and it's using the same array we're using, except Illumina has customized it to all of us just because they're so big. And we'll probably start using that same array in our area. And they're doing whole genome sequencing. And they're going to return some basic kind of things of interest, so-called traits, like can you smell asparagus in your urine, which is a Mendelian trait, and other things that have no medical significance but are kind of fun to look at. And then ancestry through the array, but they're going to use whole genome sequencing to actually return pharmacogenetics, the ACMG variants that I showed you, polygenic risk scores to participants. It will not be a CLIA report, unlike ours, which is, and that's a matter of active discussion. So there'll be genetic counseling done by telemedicine through Color, and they'll tell you you should go to see your physician to actually have it verified. So that's how it's currently imagined. It's not yet happening, still going through regulatory approval, so there hasn't been a single genotype generated yet in this data set. It'll be over the next probably several months that will first begin. A word about who we are. The All of Us Southern Network, fondly known as Y'all of Us, by the way, is a group of sites that actually came on board, most of them through the CCTS partner network. They include UAB Huntsville and Huntsville Hospital, in Huntsville obviously, both UAB and Cooper Green in Birmingham, University of Alabama in Tuscaloosa, UAB sites in Montgomery and Selma, and Tuskegee University is not an enrollment site, but Dr. Stephen Shodeke, a bioethicist there, has been helping us with engagement. University of South Alabama in Mobile, University of Mississippi in Jackson, and two sites in New Orleans, LSU and Tulane. We have very strict enrollment goals. It's going to be 93,000 over the 5 years of funding, which is a pretty big mountain to climb. And the blue shows our goals and the green shows reality. And in the first year, we were pretty far behind reality, and there were two reasons for that. One was we're a lot of sites, but each one has to go through IRB approval, the central IRB, and also has to have an agreement in place for the sharing of electronic health record data, which is a pretty complicated legal agreement. And that takes a long time to negotiate. When you have like 11 sites and each one has to do this individually, it was a pretty big undertaking to get them all on board. So for much of the first year, we were not operating with all of our sites enrolling, and it was really tough to meet enrollment goals. That's finally almost completely resolved. And the other thing which we found, it took a while even for us to learn, first of all, how to do it and to get all the pieces in place to make it done. So we started enrolling in the Kirkland Clinic. And it's a high traffic area, it seems like a good place to do this, but after a while, people who are interested have probably seen it and made a decision that they're going to do it or not. And things do eventually saturate, and you have to move on. And for a while, we were finding, we talked to folks in the health system and say, well, is it okay if we set up in this other clinic? And they'd say, well, no, it's not. It's not a research clinic, it's a clinic, and we don't do research there. And it took us a while to get everybody on board to agree that this was not just another research program. And now it's gone really well. We have no trouble getting inroads into programs all over UAB. So our numbers have surged and are pretty close to that goal. And I don't think all the data were in this quarter at the time this is put together. In fact, many times now we're exceeding our goal in a given month. And on a day-by-day basis, many of us, the first email we get every morning is the report across the entire All of Us research program, how many people were enrolled the previous day. And it's kind of hard to suppress your competitive instincts. On almost every day, UAB is either number one, sometimes number two, rarely below that, out of about 10 health provider organizations around the country. So it has really kind of clicked into high gear here. There is a lot of effort to do community outreach and engagement. One thing that I will say took me a while to learn is that engagement doesn't mean you go out to the community and you try to convince them that this is a good study and they should encourage people in the community to participate. What it actually means is you go out to the community to learn from them. What are their concerns? What are the things that are important to them if you're going to get them involved in this program? So it's much more a listening than a speaking opportunity. And Monica Baskin, who's our community engagement lead for the Southern Network, has kind of helped to set up a lot of venues. This is just a screenshot showing a handful of them. Sharonda Hardy here is our UAB engagement lead, and every week when we meet by teleconference, she's got upwards of a dozen things they've been doing, which always amazes me as to how busy they've been and how well they've done at getting the community on board and feeling respected and as a participant. So one of the things that has become concerning in the past year or so is that it's one thing to get somebody to agree to participate. It's another to get them to stay involved, to be retained so that continually as time goes on, they answer additional questionnaires, for example. And especially if you're dealing with populations that are not familiar with the internet, you might get an email that says, there's new information about your participation if you just tune in here. And that's fine if you actually have a way of getting email and a way of logging onto the internet to see the information. But by no means does everybody in the state have that capability. So the question is, how can you resolve that? So we're actually launching a pilot. We've gotten funds to outfit a bus, which is on order, should be with us in the next month or so. And it will travel around the state, and there will be so-called retention navigators who, when people have signed up or who do sign up, then there'll be a person that works with them to give them internet access if they don't have it, and to help guide them as to where to look for information. And we'll compare that to people that are not in that situation. And in addition to the bus, there will be navigators stationed at sites around the state, including at extension service centers around the state who are being sort of involved in this effort, so that there will be lots of places where we can begin to reach areas of the state that would otherwise be pretty poorly served because of their income or rural location. So here's final contact information for all of us, the joinallofus.org. Anybody can sign on if you're interested.